So today we are going to study physiology of the cardiovascular system. In order to understand physiology of the cardiovascular system, we need to be aware of some of the cardiac output variables. The first of them is the stroke volume. The stroke volume is the amount of blood that is pumped by a heart in one beat. The stroke volume depends upon the factors that are contractility, preload, and afterload. The increase or decrease in contractility and preload increases or decreases stroke volume. That is, there is a direct relation between contractility and preload and stroke volume. However, there is an inverse relation with the afterload. That is, increase in afterload decreases the stroke volume, and decrease in stroke afterload increases the stroke volume. Then we have contractility. Contractility is the amount of force generated by the heart in order to pump the blood through the arterial system and into the body. The contractility depends upon the catecholamines, calcium, sodium, and the drugs which affect these three markers. That is adrenaline stimulation, calcium, or sodium. Increase in catecholamine stimulation or increase in calcium or decrease in sodium. They increases the contractility of the heart. However, beta blockade, which is the beta blocker drug that decrease the contractility of the heart, that is through a pathway which is known as CAMP pathway. The beta blocker decreases the CAMP pathway and hence decreases the contractility. Other factors that decrease contractility include heart failure with systolic dysfunction, acidosis, that is hyperkalemia, hypoxia, or hypercapnia, that is increase in carbon dioxide concentration in the body. And then we have calcium channel blockers. They all decrease the contractility. Preload is approximated by ventricular and diastolic volume. It depends on venous tone and circulating blood volume. Vasodilators such as nitroglycerin decrease the preload and hence decrease the stroke volume. Afterload is approximated by the mean atrial pressure, which in turn depends upon the pressure generated by the atriolar contraction. So increase in MAP or increase in mean artery pressure decreases the stroke volume due to increase in afterload. Then we have myocardial oxygen demand. Myocardial oxygen demand is increased as the contractility increases, as the afterload increases, as the heart rate increases, or as the diameter of the ventricle increases. Then we have some formulae, that is, first of all them is the stroke volume. We know that stroke volume is the amount of blood that is pumped out of the heart. So it is calculated through end diastolic volume minus end systolic volume. That is the amount of blood present at the end of diastole minus the amount of blood present at the end of systole gives us an approximate of stroke volume, which is about 80 ml per beat. Then we have ejection fraction. Ejection fraction is the percentage of the blood that is pumped out of the heart. It is obtained by dividing the stroke volume with the end diastolic volume. Then we have cardiac output. Cardiac output is the amount of stroke volume multiplied by heart rate. That is, it is the amount of blood pumped out of the heart in 1 minute, and it is calculated through Fick principle. Then we have pulse pressure. Pulse pressure is defined as the amount of pressure that is obtained by subtracting systolic blood pressure from the diastolic blood pressure. That is SBP minus DBP gives pulse pressure. Then what is the mean arterial pressure? Mean arterial pressure is the cardiac output multiplied by total peripheral resistance, and DPR is obtained through the arterial contractions. Then we have Starling curves. The force of contraction is proportional to the end diastolic length of cardiac muscle fiber, that is preload. So as the preload increases, the force of contraction increases and the stroke volume increases. Contractility. Contractility is increased via catecholamines, positive ionotropes such as dopamine and digoxin. These all increases the contractility. The contractility is decreased due to loss of any functionality of the myocardium, such as myocardial infarction, beta blockers, or calcium channel blockers. So today we are going to study the cardiac and vascular function curves. First of all, you need to be aware of the concepts of ionotropy, venous return, and total peripheral resistance. So inotropy is the changes in contractility. That is, inotropy is a change in contractility of the heart, which ultimately defines the stroke volume and the cardiac output and venous return and right atrial pressure. So those factors which increase the inotropy include catecholamines, dobutamine, digoxin, and exercise. And those conditions that decrease the inotropy include heart failure with ejection fraction, narcotic overdose, or parasympathetic stimulation. And then we have venous return. Venous return is basically the preload. Those factors which increase the venous return or the preload include fluid infusion and sympathetic activity again. And those factors which reduce the venous return, it will be due to decrease in the body total volume, such as occurs in hemorrhage and spinal anesthesia. Then we have total peripheral resistance. So total peripheral resistance is determined by the pressure in the arterioles. It is increased with the help of vasopressors such as sympathetic stimulation, and it is decreased during exercise and if there is malformation. So now we are going to study the pressure volume loop and cardiac cycle. In order to understand that, you will need to see the black underlined area that is marked with steps 1, 2, 3, 4, and 5. So during step 1, the mitral valve closes. Considering here the left ventricle is full and aortic valve is also closed, the pressure inside the left ventricle increases. When the pressure inside the left ventricle reaches a certain point, then the aortic valve opens. When the aortic valve opens, the fluid from the left ventricle starts moving out into the aorta in this direction, and this causes decrease in volume of the left ventricle. At this point, the aortic valve closes. Now, after the aortic valve closes, you can see that the pressure inside the left ventricle has reduced considerably. Now, due to reduction in pressure and the aortic valve closes, and during this point, the pressure inside the left ventricle is starting to drop. Here, this you can see this is known as isovolumetric relaxation. Then at this point, the mitral valve opens and blood starts flowing from the left atria into the left ventricle. And so you can see that here the volume inside the left ventricle increases. Then again, the mitral valve closes at this point and the pressure inside the left ventricle increases. Now there are certain factors which affect this pressure volume curve. First of them is the contractility. The contractility of the heart increases, the stroke volume also increases. Due to increase in stroke volume, the ejection fraction also increases. And systolic volume, that is amount of blood present at the end of systole, decreases due to increase in stroke volume, because stroke volume is the amount of blood that is ejected out of the heart. Since stroke volume increased, so end systolic volume decreased. Then we have afterload. The increase in afterload, which is due to increase in TPR, decreases the stroke volume. Since the blood cannot be ejected out of the heart, it eventually increases the amount of blood present in heart at the end of systole, hence end systolic volume increases. Then we have the preload. Since the increase in preload causes increase in stroke volume, so the curve that will be obtained is in green. So now here is a summary of what we have studied so far. The cardiac volume pressure curve consists of 4 phases. The first of them is the isovolumetric contraction. That is when the volume inside the ventricle is neither decreasing nor increasing and the pressure inside the left ventricle increases. This is phase that we discussed here. Then there is systolic ejection, when there is blood being ejected from the heart. This is the phase that we discussed. Then there is the third, that is isovolumetric relaxation. That is when there is blood is not moving from the left atrium into the left ventricle and the pressure inside the left ventricle decreases. This is the phase that we discussed here. Then we have the rapid filling phase that you can see here, in which there is abrupt increase of blood from the left atrium into the left ventricle. And the last but not the least, we have a reduced filling phase. It is here in which the blood moves slowly because most of the blood has already shifted in the phase 4. So this is the reduced filling phase. Then we have heart sounds. There are normal heart sounds, that is S1 and S2. S3 is normal during certain conditions, however S4 is always pathological. So S1 is the sound that is produced during the closure of mitral and tricuspid valves. S2 is the sound that is produced during closure of aortic and pulmonary valves. S3 is the early diastolic sound. It is normal during certain conditions such as young adults, athletes, and pregnancy. However, it may be pathological in old patients. Then we have the S4 that is produced in the left diastole. It is also known as atrial kick, and it is due to turbulence caused by blood entering the stiff ventricle, again in the old population. Best heard at apex with the patient in the left lateral decubitus position. It is associated with ventricular non-compliance such as ventricular hypertrophy, which may be predisposed by hypertension. Then we need to understand the JVP. So there are 5 waves of JVP: A, C, X, V, and Y. A is known as the A wave, and it is due to right atrial contraction, and it is absent in atrial fibrillation. That we will study in our pathological section. Then we have C wave. C wave represents right ventricular contraction. Then there is X descent, that is the atrial relaxation and downward displacement of closed tricuspid valves during the ventricular ejection phase. Then we have the V wave, which represents the increased right atrial pressure due to increased volume against a closed tricuspid valve. And the last we have the Y descent. Y descent is represented by the right atrium emptying into the right ventricle, and it is prominent in constrictive pericarditis and absent in cardiac tamponade.